So, Dr. Cabot is here. Annie Cabot is her name, and Dr. Cabot is practices somewhere up in the middle of New Hampshire, and I'm going to let her introduce herself. For those that don't know, though, this is an MS Views and News program. It's called MS Views Now. You could see what this program is about tonight. And after Dr. Cabot does her presentation, we will be here to take your questions. Great. Thank you very much, Dr. Cabot. Take it away.
No problem. Happy to be here. And as Stuart said, my name is Dr. Ann Cabot, and I am from somewhere in New Hampshire. I'm actually in Concord, New Hampshire, and I run a multidisciplinary MS clinic. And I've been working with MS patients for over 2 decades. I did my fellowship at the University of Massachusetts, which was a great place. And I've been up in New Hampshire for a long time. And it's great. I love it. So it's an honor to be here, and I'm very grateful to be here. So thank you, Stuart, for inviting me. I think you do a wonderful job. So kudos to you for helping patients learn more about MS and all the other stuff that goes along with it. Because let's face it, things get busy in the doctor's office, and sometimes you don't get the time, myself included. I wish I had all the time in the world to spend with my patients going over everything. Sometimes you think of a question on your way out the door, or new things happen. So that's what we're here today to do. So great. And again, I'll go through my presentation today. Here's the agenda. And then we'll have some time at the end to go through some questions, which I enjoy as well. And if I don't know the answer, I'll certainly tell you, and hopefully I can point you in the right direction to get answers. So today our hope is to go through best practices in management of MS. And this changes all the time, believe it or not. So there's a lot of changes that go on all the time, and we're always updating things, and we're always, as providers, as doctors and nurses and PAs that work with patients who have MS, we're always trying to do a better job. So we're always learning and learning from each other and learning from our patients. There's lots of research going on right now. It's impossible to squish it all into any presentation. It would be a ridiculous presentation. So we'll just go over a few things. I do plan to go to the ECTRIMS conference next week, so I'll have big updates then, which will be great. So that's the Worldwide MS Conference. So, all right, so we'll go over treatment. We'll go over some updates. I picked a couple things, and then we're going to go over just a few things about, practical things, conversational things that we can talk about regarding, living in a rural community. Because, I live in a suburban-y rural community. I think some people who come to New Hampshire think I live in a very rural community. So I think it depends on where you're from, but we'll talk a little bit about that. All right, next slide. Thanks. All right, so I know most of you know this, so bear with me, but I don't think it's a good talk unless I bring up a little bit about what is MS. And I think that's because some of us are on a different path, right? Some of us have been working with MS or have lived with MS for many, many years. And for some of you, this may be one of the first times you've tapped into, a educational seminar. So MS is one of the most complicated diseases you can choose to study. And I am eternally grateful to the people who research, because without them, we wouldn't have all the things we have now. It's a complex central nervous system disease and affects the brain, the optic nerves, and the spinal cord. And we know it's potentially triggered by many things. We wish we knew exactly what caused it, but it's complicated. So there's probably lots of little things. So some of the things we think that go into potentially triggering MS could be infections, genetic factors, environmental triggers. And what happens, it activates the immune system. It creates populations of autoreactive B cells and T cells that then respond to the myelin as an antigenic trigger, and causes inflammation. And so as a patient, what you feel is the symptom caused by, let's say, we'll pick optic neuritis. I always pick on optic neuritis. I don't know why. Inflammation in the eye, you get eye pain, maybe some blurry vision. That's your symptom. That's what you feel, but this is what's potentially causing it. So that's the basics of MS. Obviously, it gets deep, but we're not going to go deep. Okay. So, all right, next slide. All right. So again, it's not easy to diagnose. Sometimes it's very easy to diagnose, and other times patients will tell you, it took me 7 years to get diagnosed. So it's completely variable. the time to diagnosis has decreased since the advent of the criteria and incorporation of MRI. MRI is helpful, very, very helpful. But we use this criteria that's called the McDonald criteria, and this is a tool that helps us diagnose MS correctly as we can, because it is a diagnosis of exclusion, meaning we have to rule out other things, okay? We use all kinds of tools. Many of you may, if you have MS, you may have had a spinal tap, you've probably had MRIs, you've had blood work to rule out other diagnoses, and that's really important because we want to do the best job we can to nail it down, okay? But it's not like we have one test that says, ding, you know, MS. There's also the possibility of misdiagnosing MS. There's actually a really nice paper that I've quoted for you at the bottom, referenced, not quoted, at the bottom by Dr. Solomon, who's also in rural Vermont, and colleagues, but they talked about how, you know, it's not uncommon to see a misdiagnosis of MS. So when we do diagnose someone with MS, it's important to follow them. And so we see you back in the office and we say, how are things going? And if you have symptoms that are not like MS, like something that may be not typical, then we may have to go back to the drawing board sometimes, and that's okay. Like, we'd rather do that than just stick a label on you and set it and forget it. You know, this isn't a chicken, this is you. And then the other thing we want to try to avoid is delayed diagnosis, right? So MS symptoms can mimic many other conditions. Sometimes I have patients who come in and they're convinced they have MS because they Googled it, right? So they're like, I'm tired. Sometimes my fingers get tingly. These are very non-specific things, right? They can happen in lots of other things, lots of other medical conditions. And so we want to make sure we're not missing those other things. And we also want to make sure that we're appropriately diagnosing MS and not delaying that diagnosis. We want to make sure that we try to zoom in as much as possible. All right, next slide, please. So this is actually, and I try to give you these resources because they can be really helpful to you if you have questions later. So this is just referencing the diagnostic criteria for multiple sclerosis. And, you know, it shows you the year. So 2017 was when they did the updated criteria. And we're going to continue to see updates in this all the time. But the 27 criteria are available on lots of different formats, but this is one from the MS Society. But it talks about, you know, dissemination in time and space and the importance of MRI, ruling out other diseases, and the incorporation of spinal fluid analysis in some cases. Long day in clinic, pardon me with my little word fumbles. Next slide, please. All right, so what other things mimic MS? So what are we looking for when you come into the clinic? So especially for those patients who have had a tricky time getting a diagnosis, maybe because some of their symptoms can look like other diseases. Things we look for are diseases like neuromyelitis optica, MOG antibody disease, Sjogren's, sarcoid, lupus, infections, post-infections, sometimes like Lyme or HIV. You know, obviously there are differences between those diseases, but it's definitely something we don't want to miss either. There's also metabolic conditions like B12 deficiencies and other like mitochondrial or leukodystrophies, which patients could be born with or develop later in life that are not MS. There's vascular conditions. One of the most common misdiagnoses of MS was found to be migraine. So migraine can cause lesions in the brain sometimes that can look like MS. And then other things like lymphoma or paraneoplastic diseases. These are not as common, and certainly there are features of MS that are different from these other diseases, but it is important to talk to your doctor if you have questions or your MS is acting differently or not, you know, the treatment isn't seeming to work. So I'm sure your doctor will want to meet with you and go over these other things as well. Next slide. All right, so what do we do in the office? Like, besides hang out with you guys, right? So what we do is to monitor your MS, one of the things is we do the MRI. The MRI is an incredible biomarker for us. So we look at the plaque burden. Those are the spots. So hopefully you look at your own MRIs with your doctor. I think it's great to do that. I think it helps explain a lot of things like symptom-wise. So we look at the spots on the MRI and we compare them to the previous MRI and we see how you're doing. We look at the T2 burden of disease and we look for enhancement. That's after you get the contrast, we're trying to see if anything's active, right? So if you get the contrast and something's active, it really pops out on the MRI pretty clearly. Now, sometimes patients don't always get contrast, so don't be nervous if you don't. Your doctor may decide you're on a high efficacy therapy or you're not having new symptoms, you've had a stable MRI for a long time, and they may say you don't need to get the dye. The gadolinium is the contrast. That's the name of the dye. We also look for things like brain atrophy. So there's good measurements that, to be honest, we never talked about 20 years ago. It's just that imaging and knowledge has grown so much over this time. Now we look at specific areas of the brain, like the thalamus. I look at the corpus callosum, whole brain, and see if there's black holes, or we look at atrophy. But it's really important to try, if possible, and it's not always possible, and I wish it was, to standardize the protocol of the MRI. So we get a lot of the patients that come in and get, local MRIs with us, and they're very standardized. But sometimes patients come from far outside, or they saw a different doctor, or they got a different MRI center, and they don't do a lot of MS. So it's really important when you get your MRI to remind the tech, say, hey, I have MS, and that the doctor said there's a special protocol for that. We want really thin slices without gaps. And I always tell patients it's like slicing raisin bread, right? If you have really thick slices of your raisin bread, you might miss the raisin. All right. In this case, if we do really thick slices with the MRI in the brain, we might miss a plaque, or the plaque might look different if I catch it in the middle versus catching it right on the end. So now it looks small and now it looks big, right? So if we have lots of little slices, we get a lot more consistency. So these protocols for standardizing MRI are, well published and available to all radiologists. So it's not like magic or secret. And all the tech should be able to help you out if you have a question on that. So there's neat studies going on. You don't have to go back. There's neat studies going on looking at brain atrophy and how those measurements can also help us. But that's techniques that at this point in my clinic, I use my eyeballs to measure. But in a lot of clinical trials, they're actually using better techniques to look at brain atrophy measures. So a lot of the bigger centers or clinical research centers have brain atrophy tools that they can also show you, mostly for research. Awesome. All right, so this is the big kahuna. What do we got to treat you with? So you get your diagnosis. Hopefully we got it right. We've ruled out all the other diseases, and you come into the office with your doctor and you're like, well, what do you got, right? So there's a lot of information here. Like, to be honest, it's kind of overwhelming. So strategy today is to say, listen, we'll diagnose you on day one, but we typically will present options for treatment, but we're not going to suggest like which one you should go on right away oftentimes, because it's just too overwhelming, and you need time to make this decision, because we do want your input. We do want your patient input, because you're the one that's actually taking the medicine. So we want to go over all the risks and benefits and give you time to be like, oh yeah, that one looks great, or that one I have questions or concerns, or my uncle's on this one, it sounds awesome. Why do you think it's not right for me? So your doctor should help you narrow down to like maybe one or two of these, and then boop, you go home, you read about it, they give you a bunch of websites, and then you communicate with your doctor about that. So what do we have to treat you with? So the first drugs we had were in 1993, the interferons, beta-seron. Maybe some of you even remember that. Those were our first drugs, and we have multiple of them now. We had beta-seron, Avonex, Rebif, and Plegridy. Those are the branded names. They're all interferon beta-1A and B. They are very helpful drugs for a lot of patients. They have flu-like symptoms for some. They are injectables. All those are fun injections. And a lot of my patients, they're not really loving that. So, but, when that was all we had, that was all we had. Okay. So then we also have glatiramer, also known as Copaxone. It used to be every day. We were all very excited when it went to 3 times a week. And so those are also injectables. And then we received the benefit of a new drug, Tysabri, natalizumab. Natalizumab is a highly effective therapy for MS. It's an infusion therapy that patients get once a month, 4 to 6, depending on your doctor. It may be different, but the studies on that were exciting, very exciting to us, because they were very effective medication. You have to be closely monitored. We checked laboratory studies to rule out risks, but these were groundbreaking days for us when we started to have high efficacy therapies. Because before this, if a patient needed a high efficacy therapy, meaning something really strong, we didn't have it that was FDA approved. We didn't have anything. So it's shocking, to think I've been treating, you know, I did my fellowship in 2002. How much has changed in this time? I feel very blessed and lucky to have all these options to share with my patients, right? So then the next group of drugs were the sphingosine modulators. I just love saying that. It's kind of a rolls off the tongue. The first one was Gilenya or fingolimod, and then there are 3 others. So when you're the Me Too drug, the next in the session, you better bring something to the party. So they're all a little different, right? So they all have little differences. And your doctor can definitely walk through that with you. What are the differences? But these were the first oral agents, the first pills for MS. And boy, was that a happy day as well. I mean, a lot of my patients were pretty excited about that. And again, every drug has risks and benefits, right? So we all need to know those, and we need to monitor our patients. But again, highly effective therapy, and a pill. So a lot of people were pretty pumped. We had other drugs like Novantrone and Lemtrada. These were infusion therapies, and we don't use them. I don't use them anymore. And then we got Aubagio and the fumarates. The Aubagio is, and these are still available, Aubagio and the fumarates. So Aubagio is a pill. It's teriflunomide. It's generic now, which is kind of cool. Pill you take once a day, not considered, you know, a high efficacy therapy. And then we have the fumarates. So that's Tecfidera and Vumerity, Bifiratam. But dimethyl fumarate is the generic now as well. So these are kind of exciting in that regard. It's a pill, it's twice a day. After that, and I'm sorry, I feel like I'm droning on about meds, but this was a big deal. We got the B-cell therapies, and we're pretty lucky that we have Ocrevus and Kesimpta, and the newest one is Briumvi. So B-cell therapies are extremely popular. We use a lot of them. If you read the data, like 50% of patients start on a B-cell therapy. We're very lucky to have these therapies. They're very highly effective. Ocrevus is the only drug that's also approved for primary progressive MS. And then Mavenclad, so cladribine, which is also a very effective therapy. This is a pill, and it's very different from our other meds. So you take a series of pills, month 1, a series of pills, month 2, and then nothing for the rest of the month. You repeat that cycle in year 2. And you're monitored by your doctor, but you do not receive additional Mavenclad in years 3 and 4. And then, you know, you decide with your doctor what you're going to do after that. So I don't get into the drugs much more in this presentation. So I did want to spend quite a bit of time on this slide, just to let you know. But I thought it was nice to just walk through these. Certainly, if you have questions about them at the end, please feel free to let me know. But it's not like we have one algorithm, you know, for treatment of MS. Everybody's going to be different, have different reasons to go on one drug versus another. All right, so how do these drugs work? All right, so they work by modifying the immune system in some way, right? So they can do a few different things. So they can sequester cells, they can regulate immune cells, or they can deplete cells. So when we talk about that, that's going to have an impact on what the side effect is and how they work and how effective they are. Bottom line, it's how you do on the therapy and what you and your doctor decide, like what's safe for you, what's effective for you, all those things. Ultimately, you're going to talk to your doctor about. So things like this, they're just for education. Okay. The important thing is to go over risks and benefits, right? So there's lots of resources for you. I'll make sure to list them at the end. And one thing we do is we categorize therapies in a couple of different ways. So to make it simple for people, instead of going through that huge list like I did with you guys, I will put them in like, here's the B cells, here's this drug, and then I try to help narrow it down that way. So we can categorize them on high efficacy, low efficacy, mechanism of action, that kind of thing. Next slide. All right, so that was part of the discussion looking at, you know, how we diagnose MS, what other diseases we try to eliminate. But I did want to touch base now on some MS research and new things that are going on. To help keep you up to date. So we're going to talk about imaging, some new therapies, and some new biomarkers. So what is a biomarker? What's a biomarker? So biomarkers are things that give us information and help us make decisions about your disease process. So I think of MRI as a biomarker. It's telling me how you're doing on the inside. It's excellent. I love it. We look at the spine, we look at the brain. Other things we can look at for MS are OCT, optical coherence tomography. That's looking at your eyes. The ophthalmologist will do that test for us. We can look at spinal fluid. We don't, I know patients don't love to sign up for that one, but sometimes we need to do it. But the spinal fluid can be very helpful in certain cases, give us more information and confidence in our diagnosis. So those are biomarkers, right? And you guys already knew what those were. So that's pretty cool, right? We also have other biomarkers that we're looking at. So a neurofilament light chain is one that's been studied for a long time. So this is measuring, you can measure serum, you can measure it in spinal fluid. Obviously, most people want it done in the serum. Serum means just a blood test, not a spinal tap. But there's, back and forth on this. So the hard part about this biomarker is that it's not specific to MS. So it doesn't, just because you have this biomarker doesn't mean that you have MS, okay? It's going to show up in things that damage neurons, so like trauma, infections, things like that. And it goes up as we age, right? So why would I use that test? And to be honest, I'm not going to lie, I was like, I don't think I'm going to use that test. However, now I'm sort of thinking about it. And people are thinking about this, well, why would we use this test? So maybe we could help it for prognosis. So to help people decide, what kind of case do they have? The other thing that people have discussed, and I think this is a very valid point, is how is the patient doing on their therapy? So what someone might consider is we do this neurofilament light chain test. It's a blood test, and you say, all right, well, we're going to then start you on treatment. Check it again in 6 months, right? See what that level is, and then check it again in 6 months and see if it's stabilized. See if it's gone down, see if it's gone up, and then the other place where I'm really curious about this is, what about patients who want to stop therapy? Could we de-escalate them? What if someone's 65 or 70 and they're like, I don't want to be on treatment anymore? Can I use this test to impart some confidence in my decision making with that patient to say, yeah, let's monitor this test and see, if it stays low? Would that be useful? I don't know, but this is something we're certainly hoping to get answers on. It does not have a standardized application yet. I feel like this is a kind of interesting marker looking for a home. So stay tuned. Basically, the slide is to say, stay tuned on neurofilament light. So next slide. So imaging wise, there's some research that I'm going to go through this pretty quickly. It's great for nerds, but may not be too interesting. You can always watch this again on the platform. But looking at smoldering lesions, and so this is things that we want to look at on imaging. So paramagnetic rim lesions, and it might be an indication of chronic central nervous system inflammation, and may tie into microglial damage and change. So awesome. Next slide. So this is images that were provided by a wonderful physician who does research down at UMass, Chris Hemmond, Dr. Hemmond, looking at 3 different MRIs. So the first one is an axial T1 weighted MRI. If you get an MRI, you get this scan. It's part of the protocol. So if you look at that slide, see the hole at the far left one? There's like a hole there, right? So then you go to axial T2 star phase, the middle slide, and you see the circle, and they highlight that circle and they pull it up, and you can see that shadow. So that there is the paramagnetic rim. You're probably, in my clinic, what we look a lot at when we look at imaging and we compare them from side to side is we spend a lot of time on the axial flare. So when you're looking at these slides with your doctor, you've probably looked at that one quite a bit, and you're like, oh yeah, I've seen that axial flare slide before. My doctor shows me that one. That's very easy to watch the spots from year to year, right? And I would always suggest, if you look at your MRI with your doctor, don't look at just this year and last year. Ask them to go back a couple of years too and check it out. Say, how much has it changed compared to 5 years ago or 10 years ago? That's kind of neat. But anyway, that shadow there might be a sign of chronic inflammation, and it might help us understand progression independent of relapses, because a lot of patients complain of that, and we see it in the clinic, and it's something that's really an unmet need in MS. All right, next slide. Oh, this slide did not come out so great. My apologies. But I wanted to make sure that you saw this paper, because sometimes this 7 Tesla which is a research tool, another MRI, can also identify, central vein sign, and also looking at chronic active lesions associated with inflammatory macrophages. So my apologies, this slide did not come out so great. I'll have to update it for Stuart later. Oh, there they are. Never mind. That's your moment of entertainment there. Okay. Oh, there you go. You're seeing the chronic active inflammation in advanced imaging. Moving on. I flubbed that one big time. We'll just move on. All right. So another thing that we spend a lot of time talking about is, escalation versus high efficacy therapy. Like, do you just go right for that first in the newly diagnosed patient? So remember, our first therapy came out in 1993. So we all started patients on that was the only therapy we had. But now we have all those other therapies. So we consider some therapies to be less effective than others, right? So over time, when the new therapies came on board, let's say you were diagnosed and you got started on interferon, and then new drugs came along, and so you moved on to, Gilenya, and then you moved on to Tysabri, and then, you kind of went that way as drugs came out if you wanted to change, right? So nowadays, many of the studies have shown that if you start a patient on high efficacy therapy early in the course of their disease, patients have less disability. This is very important because we want to prevent disability in the long run. And we know that if you look at studies, treating patients early in the course of their disease with high efficacy therapy leads to less disability in the future. And it's hard to remember that's exactly what we're trying to do. We're looking down the road, 5, 10, 15, 20 years to try to protect a person from having disability progression. So we know that treating in and of itself, just treating MS early, no matter what therapy in the past, was important to treat people, to help prevent disability. Now we can see the newer studies showing that treating with a high efficacy therapy early is more advantageous than starting with a low efficacy therapy early in the course of their disease. So again, everybody's different, and it's important to talk to your own doctor, but that's where we're leaning now. Okay. All right, so we've talked a little bit about things that are cooking along, and actually, I guarantee if you like to look at research, you're going to read a lot about these BTK inhibitors. These are drugs that are being researched right now. There's been some late breaking news, which I'll share with you, but these are oral medications. They bind to BTK and they prevent its function. They lead to decreases in B cell signaling. So, B cells are integral in part of signaling in the inflammatory cascade. Intracellular signaling molecules required by these B cell receptors get blocked off. It works on both the innate and the adaptive immune system. So that's interesting. But it also crosses the blood-brain barrier. So these are oral drugs that cross the blood-brain barrier, may have an effect on leptomeningeal inflammation, which has been implicated in progression, as well as other inflammatory signaling. So we hope that this might bring something to the party, right? Where other drugs aren't helping. So, I think the particular unmet need that we're all hoping to see some benefit are the patients who have either, progressive disease, people who progress despite treatment or progress despite, no new lesions, apparent lesions on MRI. That's why these new imaging techniques might be helpful. Despite really good treatments, they're still progressing. And there's a lot that goes into that. Remember, there's a lot of different things that go into that. As we age, things change tremendously. Our immune systems change as we age, right? They become more immune senescent. But there's this piece that we can't seem to treat, and we're hoping to find that. So we'll know more, when this data gets pushed through a little further and presented. There's many BTK inhibitors on in the pipeline, and I think the important thing is, in my mind, and other people may disagree, that these are all a bit different. Like when you look at the class, they all have different impacts on cells. Whereas a lot of other classes, we see like a lot of similar effects. I think there's a little more broad range with these BTKs. So I think there may be different risks and benefits, and we don't want to lump them all into one class, that we should be open-minded about, if one does this, then the other one might not. So we have to, be very particular about that. And I hope that they keep doing the research. So I think we'll learn a lot next week at the big conference. So great. So this is just other stuff I want you to keep an eye on. So this is a study that's ongoing right now, and maybe there's one going on near you. So just looking at CD40L. So this is a marker found on certain white blood cells. It's a phase 3 study that's being sponsored by Sanofi. You have to be between 18 and 60. So whenever you do a clinical trial, you have to meet clinical criteria, right? Which sometimes is a heartbreaker because you might really want to do one and you can't get in because you don't meet the criteria, which is, but you have to have a relapsing remitting course that then goes into secondary progressive MS. You have to have documented disability progression over the past 12 months. You have to be able to ambulate. You can ambulate with a cane or a walker, but you have to be able to move your feet. You can't be pregnant, breastfeeding, and they want you to have a normal gamma globulin level. So these are studies that are going on. I know these are studies going around me. I don't do clinical trials. I'm very much I'm in the weeds with you guys. So I don't do research, but a lot of my patients I will send to these, they have an interest in this. And so if your neurologist doesn't do research, but they say, hey, I have a colleague who does research at this center or this center. This might be something that you could be interested in. And a lot of times, you have to remember a trial is a trial. It may not work, right? So they follow you very careful in clinical trials. But, you're doing it for science. I think that's the important part. You don't want to think, it's definitely going to work or something. That's the important part. The other important thing about any clinical trial is that you can always be done. Right? Like they do follow you very close. You get a lot of imaging, a lot of follow-ups, exams, and all this other stuff, blood work. But at any point, if you decide you don't want to do it anymore, you can always step out of the study. So studies are very interesting. And certainly this is one worth keeping an eye on. So next slide. All right. And this is late breaking press release that we just all got. And, we'll learn more when this is all published, but this was on tolobrutinib. So this is one of the BTKs inhibitors, the BTK inhibitors I was previously talking about, the oral medications that cross the blood-brain barrier. So interesting, right? So this is a head-to-head trial because now with MS, we have so much data that shows us patients with MS need to be treated. We can't do placebo-controlled trials, right? Because we have all these FDA-approved treatments that show us that patients do better on these drugs. So in this trial called the Hercules trial, the tolobrutinib met the primary endpoint in delaying time to onset of confirmed disability progression in people, here's the difference, with non-relapsing secondary progressive MS. Okay, so this is a population of people that we really have nothing for right now. Okay, so that, this is what we want, right? We want something that might help people. So we need to learn a lot more about safety and full efficacy when this is published. But I think this is something that will, certainly be of great interest to us moving forward. I think the other thing that was interesting was it didn't show significance in the endpoint of reducing relapse rates over Aubagio, but it did have this disability difference in people with, non-relapsing secondary progressive MS. So that is the population of people I'm really glad they studied. So I'm like, kudos to you guys for studying this population of people that I desperately want to help. So hopefully something will bear fruit here. So that was September 2nd. So you can see up to date, right? All right, I did want to throw in a slide about generics and biosimilars because some of you might have questions about these medications and what's happening in the world. So as I mentioned earlier, we have some generics available. So generics that we have available for our patients, fingolimod, teriflunomide, and dimethyl fumarate are all available generically. A lot of my patients get them from Cost Plus RX. That's Mark Cuban's pharmacy. But what is a generic? So a generic is the active ingredients are supposed to be the same. Inactive ingredients can be different. So like fillers, colors, the little casings and stuff like that. But the active ingredients are supposed to have the same. They're supposed to have minor differences in the peak area under the curve. A generic can have a parameter between 80 to 125% of brand name. And I think most people do fine with that. I think the problem comes in if your pharmacy gets it from one provider 1 month, and it's like, there's a 10% difference down, and then the next month it's a 20% difference up. Well, now it's a 30% difference from month to month for you. So that can be a significant difference for some patients. For most patients with MS, I don't think this plays a big role, to be honest. I think the generics are fine. I think generics for some, things that are tightly controlled, like epilepsy, get tricky, right? We want those levels to be real tight. But with MS, we had good luck. I've had good luck personally, I can say, for my patients. Biosimilars are drugs that are made from living organisms. And when a patent runs out, we call them biosimilars. They're not generic. The FDA still has to approve. If you want to make a change from, like, for example, let's say your doctor has you on Rituxan, but now they want you to take Truxima. These are both monoclonal antibodies, but it's not a generic of the other. It's a biosimilar. Okay. So the pharmacy, before they can do that, or the insurance, it's usually the insurance company. They have to call us, ask us and say, is it okay if your patient switches to this? And then I let you know. For generics, oftentimes I don't know if the pharmacist switch you, they're allowed to do that. So you might, if your drug goes generic, you might just get a different, generic pill, but it's supposed to be a standardized amount. So that's the difference between a generic and a biosimilar. The concept's the same. They're just, a little different. Okay, next slide. I do want to throw in shared decision-making. I think shared decision-making is very important, because MS is, I just wanted to let you know, I took that picture. I thought it came out real cute. MS is a complex disease, right? So there's many facets to MS. Humans are very complex. You're going to have your own other things going on in your life. We talk about families, work, convenience, risks, benefits, your other comorbidities, like let's say someone has high blood pressure, diabetes, obesity, other medical conditions. We need to take these into account when we're treating you, right? And then because we have so many nice options and many of them are similar. So if I'm talking about a class, and I think that a good way to look at this one is, let's just look at B cell therapies, right? So we have 3 B cell therapies. We have Ocrevus has been out the longest, FDA approved. Then we had Kesimpta, and then we got Briumvi. So patients are often like, well, what's the difference? And I'm like, well, there's these little differences in how they're made and how they're administered. But the data, the studies all show that these drugs are very effective at treating MS, and the side effects are very similar. And the monitoring is very similar, monitoring you. So when it comes down to trying to make a decision about which one you want to go on, many times I'm like, look, if we've zoomed in on this one class of medicines, what we're narrowing down to here may be small things, like little conveniences, like you want a shorter infusion, go with the Briumvi. You want to self-administer, do Kesimpta, So they're little things at that point. They're not huge things. But it is important to know that you have choices, and it's really important to stay educated. I really don't have to tell you that because I'm preaching to the choir, because you're already on this Zoom, right? So good for you. All right, next slide. The other thing is this stuff is complicated, right? So it is nice for you to take your time to let the patient absorb the information, maybe go home and talk to friends, aunts, uncles, partners, whatever, about like, what do you think? I had this, do you have any questions? That's really important. And studies show that if you work together with your patient to make a decision, patients are much more confident in their therapy because they get it. Like they're not just saying, all right, I'll take whatever you tell me to. So they're confident in their therapy, and they are more likely to take their therapy if they had part in making that decision. That's just common sense to me. Why is it hard to do shared decision-making? Because doctors' offices are so busy. A lot of times doctors are like, what do you want? And you just, let's go. There's always this constant pressure on time. There's this constant pressure on time. So there are a lot of tools that you can use to enhance your shared decision-making. The most important one is using educational resources outside the office. So your doctor will probably give you some, a brochure perhaps on a particular drug, or refer you to a website. Those things are important. Go home and really read them, watch the video. There's videos all over the place. There's all these great videos on these medications, not only in their websites. You can look at the MS Society, MSAA, this, all of these things are excellent. So look at lots of different resources from different angles. Don't just look at Facebook. Facebook has awesome things, but don't just look at that. Look at all the stuff. And then communicate. So write down your list of questions. I portal with my patients a lot. So that means they email me through the medical record and I send a message back. If they have too many questions and clearly don't, it needs time, then my nurse will call them back. If that relationship is really helpful. And I think communicating with your doctor, I think patients don't understand. I love hearing from them, So, we want that relationship with our patients. That's what's great. We want to make you feel better. That's why we go into this, right? So don't forget that. We want to help you. Awesome. So when is it time when does it matter? I think this is important to me. So when does it matter about shared decision-making? So if there was only one pathway for the treatment of MS, we wouldn't bother with shared decision-making. I'd be like, well, obviously you go on drug X and then we do drug Y and then we do this. That's not how it is. There's no strict algorithm, right? So that's one reason, right? So pregnancy planning, all those things, every doctor might do things a little different. The art of medicine is very much at play here. Starting, stopping, and changing therapies. We don't really have great science on this. We have a lot of experience with this, but it's not like there's a study that says, well, if you're coming from drug X and you're going to drug Y, this is what you have to do. So there's a lot of communication involved there. The other important part of shared decision-making is managing symptoms, all right? So I would say outside of diagnosing and treating MS, 90% of my job is managing symptoms with you guys, right? So this is a partnership because I depend on you to tell me how the symptoms are. And then we try lots of different interventions to see if we can make them better. That requires a lot of patient input, right? So, all right, next slide. It's fun stuff though. All right. So speaking of symptoms, we treat things like memory problems, spasticity, weakness, bladder and bowel problems, mood problems. But we also talk to our patients about stressors, like financial stressors, emotional stressors. We try to get them resources. And a lot of what we do is educational, and pointing them in the right direction. So, but the symptom management is really, you can get a lot out of treating the symptoms. The hard part for patients is many of these symptoms are invisible. So this can be extremely frustrating for patients. I actually love it when people bring in a friend or a partner. The kids are great to bring. So if someone has teenagers, I'm like, bring them. Because then number one, I can show them the brain MRI. And I think that helps because you don't oftentimes see MS on the outside. It's invisible, right? So patients can be like, oh, you really do have MS, and you're like, of course I do. So that's really helpful. But the other thing is we can talk about those invisible symptoms and help people understand that they're real and what we can do to help them, right? So that's very helpful. So a lot of things, I put the circle in here, of symptoms, because a lot of them feed off each other, right? So I often use the example, if someone has bladder problems, maybe they're embarrassed and they don't want to go to the gym anymore, so they stop working out, then their spasticity gets worse, and then they're not sleeping well, they feel bad about themselves, and you're gaining weight, and all this could have been fixed if the patient just treated their bladder symptoms, right? So you want to make sure you're paying attention to these things. They're not little symptoms. They're important quality of life squishers, if you ask me. So we want to get rid of them to the best of our ability. Now, sometimes that might mean I have to work with a team, physical therapy, PT, all that stuff. But anyway, don't blow off your symptoms. I think sometimes we just get so used to them. It's easy to be like, well, I just deal with my pain, or I deal with my depression. It's not worth it. Go get it treated. So if you get one thing out of this talk, manage your symptoms, and work with your team. But a lot of times it takes input on your part. So it is work on your part to treat. If you go to the doctor and they say, listen, quit smoking, eat right, and exercise, and you're like, I don't really want to do any of that, you're not going to get far, okay? So definitely take the advice, but take the tools. They're not going to just say that and not set you up with PT and a nutritionist and all these other resources, right? But it is work. So, but you're worth it. You're worth the work. All right, next slide. All right, I thought I'd throw in two cases just because I think it's very relatable. All right, so let's look at the first case. So next slide. Sorry, fast on that one. All right, so this is just an example. All right, it's a 27-year-old with a history of sleep apnea and obesity. So she comes to the clinic with new onset right eye pain, blurring. She had a little bit of tingling on the right side of her face. You know, in retrospect, she had some symptoms 2 years ago and they resolved. And we did the exam and we see that evidence of old optic neuritis and some hyperreflexia. So her reflexes were really brisk. She also has a family history of MS, so that increases her risk. Next slide. So on this slide, you can see that this patient has characteristic features of MS on her MRI. She has paraventricular lesions on the brain, and she has a single spinal cord lesion in the cervical cord on the right. So there's a little arrow looking at the spinal cord lesion, because I know if you don't look at MRIs every day, you might not notice that. There's a little line in the spinal cord. You don't see my cursor, or I'd show you. And then the brain, she has what we would call a fairly low burden of disease. She doesn't have a whole lot of spots, but they're classic spots. She's diagnosed with MS. All right, next slide. This is a completely different patient. So this is a 57-year-old, which is a fine age, I'll tell you. But she's had MS for 30 years, right? So this patient was diagnosed when she was 27, right? It's just like the last patient. But because she didn't have probably the advantage, right? Well, we know she didn't have the advantage of all these wonderful medications that the newly diagnosed patient has. This patient has a very heavy burden of disease. So you can see she has a very heavy burden of disease in her spinal cord on the left. There's even cord atrophy. She has a number of lesions on the brain and some brain atrophy. So her corpus callosum has some shrinkage. You know, and these are things that we would look at in the office, and it might help explain symptoms, right? All right, next slide. So if we look at patient 1 versus patient 2, they have incredibly different stories, right? Patient 1, her symptoms got better with some steroids. She gets on treatment. Hopefully she picks a high efficacy therapy, has no side effects. She starts exercising, eating right. She loses some weight. She feels great. Nothing ever happens again. That would be my dream, right? But patient number 2 has fixed deficits, right? Patient number 2 with that heavy burden of disease in the spine, the spinal cord atrophy, she is going to have problems with spasticity. She's going to have problems with bladder and bowel, weakness, gait dysfunction, all that. She has atrophy, so she probably has some issues with cognitive function. She may have fatigue. So we can work on every single one of those symptoms, but the patient who's had this disease, you know, without the benefit of those high efficacy therapies, it's really a very different scenario. And I think the most important thing to take away from imaging is that every one of us, it's like a fingerprint. Everyone who has MS is so different. It's the most heterogeneous disease going. So, so we end up partnering up for the second patient. So she sees a urologist, she sees a mental health provider. We do cognitive testing. We set her up with physical therapy to keep her as the best she can be. We sometimes have to help them with VNA and social worker. Physiatry, so physiatry helps with spasticity and mobility, bracing. There's neuro-ophthalmology. We work with orthotists, radiologists, you know, so the whole team. There's more, but I probably forgot them. And then we try to connect our patients to wonderful resources like you're listening to tonight. So definitely stay involved. All right, next slide. I loved this picture of the eggs. One of the nurses in my office has chickens, brings these into us every once in a while. And I think they're so beautiful. And when I looked at it, I thought about my patients and, you know, let's face it, these are all eggs, right? But they're so different. And that's how MS is. So MS is, it's just a little different for everybody, right? So, but they're all eggs on the inside. There you go. So I did love that. Love that picture. Great. Next slide. So, all right, this is a slide I never thought of putting in here before, but I thought it might be nice to put in here for you. When do you stop therapy? Well, we never had this problem before because remember, we only got therapies in 1993. So it's a good problem to have. And we all do this a little differently. Here's another example of where shared decision-making is just awesome because we don't have an algorithm. There's a bunch of studies out there and you can definitely look at the studies. So when my patients get to a certain age, we start talking about this. It depends on a lot of things like how active is their MS? What's their biological age? How's their MRI looking? How nervous are they about stopping, right? I mean, there's just a lot of things that go into this. But it's important to remember that there's risks of our treatment too. So I don't want to put my patient at risk, because as we age, our immune system gets, we get immune senescence. We start getting, our immune system calms down. Patients tend to have fewer relapses. Normally with aging, it's like a bonus, right? We get older, we get wrinkles, but we get less relapses. So we do continue to monitor patients, even if we decide to come off therapy. I think that's especially important. And it's really important to have good communication with your patients. Okay. So if the patient goes off therapy and has new symptoms, we can put them back on treatment. We can treat the relapse, but relapse decrease as we get older. So now every doctor is going to do this a little differently. So please don't ask me the question of when do you stop patients, because it's going to be different for everybody. Okay. Next slide. All right. Last section, I promise I'm talking longer than I'm supposed to, but caring for patients in rural communities and how we do it. So I don't think, there's actually a ton of research looking at general health in rural communities. So when you start researching MS patients in rural communities, I mean, I can definitely tell you it's a challenge. Okay. So some of my patients have to drive 2 hours. Some of them don't have adequate transportation. Some of them don't have adequate internet. Like they don't have good internet. I find that horrifying. Some of them don't have folks who can take a day off of work and drive them down if it's a long drive. So there's a lot of things that go into this. They might be very far from a healthy grocery store, right? Like all the things that go into good health that we don't, if you live in like a suburban or urban area, you may take for granted. They call them like almost like a grocery desert, right? Like there's no food, healthy food, and all that stuff. So there's a lot of geographic differences in wellness and healthcare and resources for patients. So bring it to yourself. So how can we help bring the healthcare to you? I think the best way, and if you're on here, you already have a computer, right? So, but if you don't have a computer and you don't have the resources for the computer, tell your doctor. We have different foundations that can help patients get computers if they qualify. I've had lots of patients do that. Like some of my patients are like, well, I have a phone. That's very helpful. But, having a bigger screen can be great. That has been hugely impactful for our patients. Once we get them a computer, or if they already have a computer, then they can take advantage of many, many, many things, right? So they can take advantage of telehealth. They can portal message with their doctor. We have educational classes for our patients. So we have a mindfulness class for our patients. We have yoga for our patients. We have book club, writing classes, peer wellness, all these things that are there to help the patient be stronger, healthier, more resilient. And that makes their MS easier to deal with. Right? So if we can get people connected that way, it's excellent. Because studies like this one that were done by Dr. McGinley, who did an excellent study, and you can see this is a hot topic. This was just published in January, showed that there's a shortage of neurologists. Just, we all know that. I'm not that far from Boston. Okay. So, we can get to Boston pretty quickly. There are 6 MS centers or more in Boston. I mean, there's a ton in the greater, Metro Boston, I don't know what you call it, Metro Boston area, right? So, but as soon as you get outside of a large city like New York, Boston, Philly, all the Jerseys, you start to see a decrease in how many neurologists are available. So just a general neurologist starts getting to be a shortage. And we know that this is not improving. So the number of people who go into neurology is not great. And there's a lot of older neurologists who will one day want to retire. So the access just keeps getting, unfortunately, a little worse. So I think this platform is going to be increasingly important for patients. Access in this study was found to be decreased in areas with higher proportions of Hispanic patients and in populations where there's increased disabilities and the uninsured. So then if you talk about MS subspecialty care, because I run an MS clinic, that's even harder to get in a rural area. So this is a tough situation, but I think we can do lots of things. I would suggest if you live in a rural area that you advocate. If you have a local neurologist you work with, there are programs that they can tap into to help connect them with an MS specialist. And there's a lot of things that we can keep doing moving forward, but the patient has to do the work, which is always a little hard. I get it. So next slide, sorry. All right, there's another study looking at disparities in telehealth in different populations of patients. People who are at disadvantage for telehealth are people of older age, lower socioeconomic status. I will tell you, I know this for a fact, like if I have to log on with patients who are maybe older, some of them, no problem, like Zoom right in. But some of my patients, like, we'll spend 10 minutes trying to get the video to work on the, they get the audio to work, they can't get the video to work, we're struggling away. It's just clunky to them. So more impairment, so higher levels of disability are associated with less access and use of telehealth services. So we want to eliminate these barriers. We want patients to be the best they can be, but we do need patients to speak up. So make sure to tap into some of your resources, talk to your senators, send them an email. You're always going to get, if you sign up for alerts from like the MS Society, you're going to get alerts to access to broadband and all those. Always, send those into your senators and things, because if they hear from you, then they know it's a problem and they will hopefully help. They hear from one of you, it helps. They hear from 2 people or 3 people or 10 people, it's very impactful. So the more you do, the better. Next slide. Use your team, use telehealth. When you're in a rural community, you use your PT, your OT, your resources, mental health resources. You use your local community. If there's someone in your town who's retired and it's like, I'll give you a ride, take them up on it. If they have a good license. Use the broadband, use the internet, make sure that you fight for access for that. Utilize every wellness program. Sometimes I tell people about things as simple as silver sneakers and they're like, huh? I'm like, you can do Tai Chi on YouTube. You can do seated yoga on YouTube. It's not that fancy. Go look for it. Don't look at popular culture stuff. Sometimes dedicate time to yourself. Give yourself that 30 minutes of exercise a day. Make yourself better and tap into your support groups. Next slide. So yeah, here's some other resources, but I did mention a lot of those already. Those are for professionals too. So if your neurologist is stuck, they can use those. Next slide. Here's my summary slide. Sorry again for talking so long. So we talked about the diagnosis of MS, treatment of MS, comprehensive care, the heterogeneity of MS, and the resources available to you. So I hope you take advantage of those. Excellent. I got a couple resources for you, references that you can certainly review if interested. And that's the end of that. Sorry, I went a little over.
Well, thank you very much, because you may have gone over, but I didn't want to cut you off. That was very good dialogue. Something very much needed. So thank you. All right.
Yeah.
So we do have a few questions. All right. And we have a few questions from people online, and we have a few questions from people that wrote in questions. So, but one of them I do have was that MS Views and News has great resources, all right?
Yeah, I apologize. I assumed it would just be, obvious.
MS Views and News has great resources. It should be in print also, but
I'll add it in.
we're going to add it in when I do everything else. Yeah. So,
Yes.
But what I need to let everybody know, and I did put it into the comments so that way you can click on it and you could see. I put it in the chat. You could click on those resources and find it. All you have to do is go to our website and you go across the top of the bars there and see all the different things that you have available for you. And one of them is the resources page, which took us almost 4 months to put together. So I'm really hoping that that you all can check it out one day. All right. Thank you again for speaking, Dr. Cabot, and let's get into the questions. A person online writes, has anyone studied why most female patients feel better and often don't progress with MS during pregnancy?
Yeah, great question. So the question, pregnancy and MS is a really interesting thing. We know that patients, when they're pregnant, have a decreased risk of relapse. And then in the postpartum period, there's an increase again. So the hormone they think may be responsible is estradiol or estriol. And there's a protective effect of pregnancy, right? The problem is that we can't just take hormones because the risks, and then, what about our male patients too? So that is something that has been studied. And there's also a lot of additional research going on right now about pregnancy and MS and what meds are safe and things like that. So this is a real hot topic. I think the data gets better and better all the time for treatment of pregnancy and MS. So yeah, so that's been studied for years. And again, a lot of variability for what different doctors will do, and this is an excellent time for shared decision making if someone's planning pregnancy, what to do about treatment before and after. And there's a lot of research on that, which is really good. So hopefully that's helpful.
Great, thank you. So while the women are feeling better while they're pregnant, what do men get to do?
They get to not be pregnant. They don't have to
That would
push
be
it
a
up.
good thing. That would be a good thing, yeah. All right, thank you.
I
Thank
do
you for
have
that.
like literally, I wish I could just stay pregnant all the time. Like they felt that good. Like energy's better. Like a lot of things get better. We know that protective effect is strongest in the third trimester. It's not as strong in the first trimester. So it definitely increases over the pregnancy.
Maybe that's why some women with MS seem to get pregnant often.
Yeah, maybe.
Yeah,
Oh,
maybe.
Yeah.
All right, next, is there they spelled it wrong, but I know what's being said. Is there an NSAID, anti-inflammatory, for MS?
Nope. We don't have an anti-inflammatory specific for MS. So if someone needed a non-steroidal anti-inflammatory for like, joint pain or something like that, they would want to talk to their primary care or their neurologist about that. If you're asking specifically about, is there an anti-inflammatory for the brain in MS? That's a really good and interesting question, because the medicines that we have sort of do work in different ways to decrease inflammation, right? So if you talk about like Tysabri or a B-cell therapy, these drugs are very, very effective at reducing inflammation in the central nervous system. So, but they're different compartments and they're treating different things. So great question.
Thank you. Good. How long does it take for medicines to get approved by the FDA from the onset of when they're first introduced?
I probably have to look that up to be accurate. I'm not exactly sure.
Okay.
First, they have to go through phase 1 trials. Then you go through phase 2 trials. Then you go through phase 3 trials. So they're very small at the beginning, and then they get phase 2, and then phase 3 are the big trials. So the big trials then have to be presented to the FDA. And I do believe it's a little bit variable, depending on, what's going on. It can happen rapidly, especially if they push it through.
Right. Well, that was the next question, is why can't they fast track MS meds like they fast tracked what was used for COVID?
Oh, well, I think we have very good medicines to treat MS already. So you'd have to have a really good reason to fast track something, because we don't want to have a safety problem and then be like, oh, shoot, this is. And I also think, we're talking about very different things, right? Like for the most part, MS, we already have these good treatments, and it's not going to kill you. When you're talking about millions and millions of people and many people dying, it's a very different pressure situation. So the timing of those, MS is also really hard to study, right? So MS is a very slow disease to study. So if you look at MS clinical trials, the shortest ones you're going to find are 2 years, right? Some are 3. The best studies are longer, right? And then we have extension studies on top of that, because if I get diagnosed at 21, I'm having this for 30, 40, 50 years, right? Like I'm having this the rest of my life. So whatever I'm taking, I have to think about, if I take a drug now, what's going to happen? Can I predict? No, I can't. No, because they only studied it for 2 years, right? But that's actually a long trial. If you're looking at things like, an infection, you get the infection, it's gone in 2 weeks. That's easy to study, right? Like your studies are rocking and rolling right there. So it's just a very different scale, of time. So that's probably the most.
Okay. Thank you for that. By the way, for those that came in late, my name is Stuart Schlossman, and now you know who I am. Somebody asked me that. They asked me who I am. They know who you are. Right. Who's that guy? Who is that guy? Right. All right. So the next one, and this is a question that was actually asked of me the other day, and somebody wanted to know if multiple sclerosis is known not to kill a person, then why is it that they hear that secondary symptoms can cause somebody to die?
Great question. So with better treatments, MS patients are living longer. We used to say that the life expectancy of someone with MS was 7 years less, right? But that's changing. So when people have significant disability with MS, so let's say a lot of mobility issues, spasticity issues, the problems that we see developing typically are things like pneumonia or UTIs, sepsis, falls. So our hope is by preventing advanced disability of MS, we will see fewer of these disabling secondary complications of MS, right? So sometimes when people have, like, let's say you fall. Well, the fall wasn't necessarily from your MS. It's from the spasticity that maybe not be treated well, right? So that kind of thing. It's like a secondary thing.
Right.
The medicines we have also have risk. So never forget that. So while our medicines are very effective, there's potential risks to the medicines compared to placebo. So it's important to talk to your doctor about what your specific risk is, because my risk is different from somebody else's risk is different from somebody else's risk.
Okay, thank you. Next one, person writes, what does it mean if our corpus callosum has atrophy?
Okay, so that's just that connects the two hemispheres, right and left. Okay, it's got a lot of white matter in it, and we often see a lot of the lesions in the corpus callosum. Okay, so if you look at if you Google up like MRI changes in the corpus callosum of people with multiple sclerosis, you'll see some patients won't have much, right? Other patients, because all our brains atrophy as we age. Okay, with MS, sometimes that atrophy is accelerated. So oftentimes you can see atrophy in different areas of the brain. So the areas that we look at, and in the slide that I showed you, there was particularly, you could see corpus callosum atrophy, which is why I mentioned it. You can see thalamic atrophy. That can be predictive of cognitive issues. Brain atrophy can be characteristic for patients with thinking and concentrating issues. And sometimes I see patients with atrophy and they really have no complaints about any of those things. Again, it speaks to the heterogeneity of the disease, but I will happily always look at patients' brain atrophy measures with them in the office when I'm looking at the MRI.
Okay, thank you. Sativex. It's been used in many places outside the United States. Why is it not used in the United States?
I don't know. Sorry. I don't know why.
Why not?
I don't know. I don't know.
Okay. Is there a reason? Is it not being studied?
I don't know. Beyond my capacity. I'm sorry. I'm just a little doctor in New Hampshire. I don't know everything.
Okay. No problem. All right. Next. Thank you. Next is, what is the Concord Hospital Wellness Program and can we access it?
So the Concord Hospital Wellness Program is developed by our team. And we have, because we have a lot of rural patients, we've always tried to get programming out to people that was convenient. I know that it's hard to stay in shape. Like, I know that it's hard to find time to exercise. And I know that there's sometimes, limits. Sorry about my crazy hair. Limits on what people can do, like where they can drive and stuff like that. So we started the program with a peer wellness program that was really the brainchild of another person in my office, Dr. Oliver, who's just awesome. And he really brought this program along. And it's really to help motivate patients and partner them up with a buddy with regards to kind of, how are you doing? Not only that, like emotional part, but also like, what are your goals and how can we achieve your goals with wellness? Speaking of wellness in particular. So these are trained mentors that help patients on their wellness path with MS. So that's one program. Another program is called Mindfulness. We call it Mindfulness. It's MBSR, but it's a stress reduction program. I think all of my patients say they're stressed. They're like, who wouldn't be stressed with MS, right? But sometimes it can help with sleep or insomnia. It might help with cognitive function to help reduce stress. Meditation has been shown to be very beneficial for a lot of people. And I like to do things that aren't always drugs, So I try to avoid using drugs for symptom management whenever possible because all drugs have side effects. So if I treat your spasticity with tons of baclofen, and some patients need that, But if you can augment your spasticity management with some yoga, and we don't have to use as much baclofen, way better. So we try to pepper in the wellness programs to help reduce. Well, it's got a lot of benefits because it's also like social, and we know that people need to socialize, right? And when you're in a rural area, that's especially important. Other programs we have, there's a book club and a writing club. I love the writing club because there's a person who teaches writing, and she'll say, you know, here's the topic, pencil, 5 minutes, write. It's just so good for your brain. Nobody's grading you, you know, but we want to keep that thing cooking. We want to keep your brain moving in different ways. You know, so these are really cool programs. The programs are all free. We have a painting class. That's one of the favorites, but that's in person. That's the only limitation of that class because we provide everything, including the teacher and the canvas and the mess and the cleanup, and the cookies. So, yeah, but these programs are free because we have a grant, but they're only accessible to our patients because otherwise they would clog up. So they have to be a patient of ours.
That's good. That's good to hear. All right, next, we have a person that writes, I have to drive 4 hours to my MS neurologist and stay overnight. It gets very expensive. And so I actually, you know, we hear this on a regular basis, and that's why we favor telehealth. So what do you tell your patients that may have to drive to you from 4 hours away? Do you prefer that they do a telehealth call with you?
I don't want to burden someone. So I think there's a lot of reasons that you can get away. It depends on your situation, right? So if you things are stable and you're doing awesome, look how much I can do on telehealth. I can check your, you know, boop, boop. I can I can have you get really close and I can look at your pupils. I can be, I can't check your blood pressure. I can't check your, I can check your walking. You can get up and walk in front of the camera. If you can't walk, I can have you try everything else. If you have a person with you, they can help you with the exam. I can do an eye chart and have you read it. I have a big red swath behind my telehealth in my office so you can look, you know, one side or the other, and I can see if you have red desaturation. If you're having an acute problem, it is not the right tool, right? So if you have acute optic neuritis or something, well, maybe it is, like maybe it is. But I'm all for it. I'm all for patients not driving and spending $300 to get to the neurologist when I can do most of it in the office. I think the hardest thing for me is that I can't really tell someone's tone. Like if someone has a lot of spasticity in their legs, that's a little tricky, but you could describe it, you know, so we could try something and you could tell me how it works. I can do the prescriptions online. You can do the Tai Chi on YouTube. You can use Silver Sneakers to do all the wellness stuff. You know, I think there's also resources out there. Certain hospitals will help pay or defray the cost of your travel. Maybe you get a grant for, or apply for funding. I know the MS Society used to do it, but I'm not sure they do anymore. They used to help patients like that. But it's worth asking, you know, because that sounds like a burden. It is a big burden, but every once in a while you may be like, it's totally worth it for me to go. You know, you maybe really find it. What some of my patients do, because I offer that, and sometimes they're like, nobody really want to come down. I'm like, why? And they're like, because I make a day of it. I go shopping. I bring my friend Gertrude, you know, they have a good time. So, you know, you could set it up like that too, like make a day of it if it's fun, you know, if you can make it fun. So,
Sure. Sure. Okay, great. Thank you for that. By the way, for those that don't know that are online, we have a once a month physical therapy with Dr. Gretchen Hawley, and we have a once a month Pilates class, and we have a once a month mental wellness class, and we're just starting again next week, once a month chair yoga. So, you know, you can always come to us and check those out, and it doesn't cost you anything. All right, next person is asking, say that again?
Thank you for that.
You're welcome. You should tell your patients about it.
All my patients, thank God I get this.
You should tell your patients to look at our resources too.
Well, you are on a resource sheet that I give out to every patient. Then it's up to them to go. But now that I know you have,
you know what? I'm going to send you all the. I got to send you a box of brochures about what we have. So.
Yeah. All right. So we'll turn it around. We'll tell you to do that. That'll be amazing.
No problem. No problem. All right. I'm making that note. All right. All right, next we have a person asking the following. How do you distinguish diagnostically between multiple sclerosis and MOGAD? This is a great question here. And can someone have both? But let's go a step further with all this. How do you tell the difference between MS and NMO, or MS and myasthenia gravis?
Sure. Okay. So MOGAD, for people who don't know, is a syndrome, and we used to think it was MS, and same with NMO. We used to think it was MS, but researchers helped us out a lot, and they've realized that, there's something different about these patients, right? So MOGAD is different, distinct entity from MS. Okay, so MOGAD patients usually have a couple of different things going on. So all three of those things, MS, MOGAD, and NMO, patients can get optic neuritis and spinal cord disease, right? So what are the differences? So for MOGAD, sometimes it's a once and done phenomena. About half of our patients may only have one event. The other half relapse, and we don't know why. Okay, so the optic neuritis can look like MS, but sometimes it's more severe. And if they have spinal cord disease, it's often in the lower part of the cord. So patients will also have a lot of bladder and bowel complaints. All right. So those are a little bit of a clinical scenario difference. The best thing we got, though, is the blood test. So we got a blood test now. Woohoo! So life is easy. We do a blood test. It's a biomarker. So we check MOGAD for our patients who have optic neuritis, and we check a blood test. I send it to the Mayo Clinic. And there's a different titer. The titer's helpful. And again, this is an evolving field. So we're learning about MOGAD. I'm lucky, I know people who specialize in this and do research in MOGAD. So if I have a case where I'm stuck and I'm not sure, MS is definitely, and MOGAD, this field, neuroimmunology, is a field where you phone a friend as the doctor. So if I'm not sure, I'm phoning a friend. So, because there's a little bit of a clinical crossover. So there are probably people out there who are diagnosed with MS who, in fact, now that we have the blood test and we run it, maybe they had MOGAD, but it's treated differently. We don't use MS medications in MOGAD. So, so clinically they can look fairly similar, but if you're someone who sees a lot of MS, I'm like, oh no, that sounds like MOGAD, or MOG. So the titer, again, very helpful. And typically the spinal fluid is going to be negative for MOG and negative for NMO and positive for MS for oligoclonal bands. So we're looking at different things. NMO, to me, is a completely different animal. So NMO is a very aggressive disease that has optic neuritis and spinal cord lesions, but these are different. They're typically longer lesions in the spine. Patients don't recover as well. It progresses very rapidly. It's associated with microhemorrhages, and it's treated with different therapies as well. So again, we're so lucky we have a blood test, and most of the time this blood test will pick up NMO. So it's an extremely helpful thing to have these labs to increase our confidence in the diagnosis of these things, because of course there's a little bit of crossover. Probably 5% of our MS patients have a positive MOG antibody. So there can be a little bit of difficulty clarity there. If you're one of those patients who's not sure, that's a patient I would absolutely send to an academic center and say, this one's in the middle. What do I do? Or I'd hook them up with an MS or MOG researcher. So there's a lot of research going on right now with MOG.
That's great to hear that you're so proactive with that, because the big problem with NMO specifically, and I know this because we are doing educational programs around the country on NMO as well, but the biggest problem is that your MS experts can know that when their patient is not doing well, let's do the blood test. But when your community doctors, which most people in rural America have, are not seeing that, and unfortunately, people are slipping through the cracks and being misdiagnosed with MS that have NMO.
I have to say, I think there's been a huge uptick in education, probably because of programs like yours, because, a lot of ERs, because a lot of patients are going to present to the emergency room. It's going to be an emergency room doc who first sees the patient. And a lot of times now they know to do those labs. So the problem is those labs may take a little while to come back, right? So
Right.
that is a sticky thing. But I think there's definitely an awareness. Now that we have treatment for NMO, there's more of an awareness. I think it's always tricky when there's not a lab and there's not a treatment, So
Great.
blessing.
Thank you. Well,
Yeah.
my thanks to Cindy for bringing that up, because that was a great question asked they're all good questions, but that came up out of the blue, and I'm glad that she asked that. So, all right. By the way, you hear me say just first names, not last names, so I'm not embarrassing anybody out there. All right, next one. I'll say the last name. No, I'm joking. Person writes, have you heard much about nasal DMT may be coming out?
No, I'm glad you asked. I don't think I know enough. I am going to ECTRIMS this week, so I will keep my eyes peeled and see if there's anything out there and get back to you if that question persists, but not at this juncture. I mean, there's a ton of stuff, right? I mean, there's endless amounts of research going on. It's just how much is coming close, right? Remember phase 1, phase 2, phase 3. I get excited in phase 3. I've in my 20 years now, I don't get as excited. I should, but I don't get as excited in phase 1 and phase 2 anymore. I really get excited when phase 3. So there's a lot of cool research going on out there. There's certainly a lot of optimism, and I think it's warranted. So
yeah. Well, we're involved with a lot of it. The pharmaceuticals bring the patient advocacy groups in many times to get our opinions on things, and so it's really cool that we hear about a lot of these things that are in phase 1, and with great hopes that I'll be around to see if it's approved, because could take many years. But other things, like you said earlier, they just get sped up a little bit, and it's nice to see. All right, next person writes, do you think AI can be a good thing for treating, in part, those with multiple sclerosis in rural areas?
What a cool question. No one's ever asked me that. I'm like super pumped about AI. I'm not a computer person, usually. But the other, I think it's going to be interesting. I think where this might be really interesting, maybe looking at MRIs, like if they can get the AI to do the comparisons and the atrophy measures instead of just, me spending 20 minutes looking at it, they're going to get, someone to do that. I think another thing where I've been playing around with it is in developing, like let's say someone comes in with bladder problems with their MS, and I can generate like a handout for the patient. So I can say, okay, this is what we talked about today, but I want you to take this home and read it. And it's specific for them. And AI, like I'm playing around with that, and it's actually pretty good. But I still have to proofread it because it's just pulling. So I think things like managing constipation or managing spasticity, those kind of things, it's pretty good because there's a lot of data out there for it to mire. I do think it's going to be a big part of the future, and maybe a very positive thing. I hope. Again, I wish I was more of savvy. I'm not. That's my age.
Okay. It's okay. I don't think most people really understand most of what's going on with AI and especially medical conditions or the symptoms or even the treatments that could be available in the future.
So one place where I think it'll be really neat, this is one example. Okay, so one example. So you remember how they used to talk about gut microbiome and how that might be important in MS and blah, blah, blah. But the problem was you look at all the gut microbiome stuff and it's overwhelming. There's so much data. Every bacteria has its own little genome and all, so you need AI to like process that kind of level of data, I think. So
if you use GPT, you could ask these questions and you will get the answers. They just come out. As soon as I get done asking a question, it's like 2 seconds and a whole stream of things are being answered, and it's totally incredible.
Yeah,
totally
and I know doctors are using it like for chart generation, and because documentation is a huge pain for us, and we spend endless hours writing notes and finishing documents, and it's half our time, right? So be able to ease the burden of some of that.
Okay, next question. We have several questions remaining, so I got to get through these before you go to sleep, all right? Have you heard of the app Be Care? The results can be downloaded as a PDF and shared with a provider.
I don't know that one. See, learn something every day.
Me neither.
Or if I heard about it, so there's that.
I'm going to ask the person, I'm not going to say her name, but I'm going to ask the person that just sent this, send me an email about that because I would like to look it up, all right? Thank you.
Yeah.
All right, next person says, I spoke recently with my neurologist and shared that the differences or types of MS are falling out of favor. How do you feel about that? I now just say I have MS. Oh,
Perfect.
gotcha.
Yeah, no,
Yeah.
I think that's starting to be the trend. We love to put things in a little box and be like, you're this or you're this. I've never liked that. I've never been comfortable with it. I'm all for, we're on a spectrum of MS. Let's just call it MS. Yeah.
Right.
So,
Yep. There's a lot of doctors that are on our programs now saying that as well. And they're just killing off the relapse remitting SPMS, PPMS. You have MS, you have MS. That's it. Let the doctors treat it. Let the doctors treat it. You don't have to say to your family and friends, I have XYZ MS, and just deal with it. Just deal with having MS, right?
Yeah. Great point to bring up too. So
thank you. Have you ever heard much? Oh, no, we already did that one. Never mind. Sorry about that. Did that one. All right. How can primary care and neurology partners together
great.
to help? How can primary care and neurology partner together to help MS rural care?
I think you have to do that. That's absolutely. So in the slides, there's some resources for primary care and general neurologists. There are programs, CE programs, so continuing education programs for PCPs and neurologists. And to be honest, I know primary care doesn't have a lot of time, but I'm always happy to speak to primary care. And again, if someone had MS, I would want them to teleneurology with me. I want to drive the bus. I don't want to put that in the lap of someone who doesn't treat it all the time. I think that would be a lot to ask in primary care. But to be honest, treating spasticity, bladder bowel, gait dysfunction, a good rural primary care ends up doing a lot. So they're going to be the ones to, if you get a pneumonia, they're going to treat it, to give you your vaccines, stay up to date with your vaccines. They're going to be the ones to make sure you're doing that. Are you up to date with your cancer screenings? Because some of our treatments increase your risk of cancer. So make sure you're up to date with your cancer screenings. All that's really important.
Which ones do that?
There's studies that show that all patients with MS are slightly at increased risk for malignancy. So I'd always encourage all my patients to get their cancer screenings because you want to stay ahead of cancer. It's very treatable that way.
Quite true. Quite true. All right. So are there medications, MS medications, being used in Europe or Australia or Canada that are not approved in the United States?
Well, the interesting thing is Mavenclad was approved earlier in Europe than it was here in the US. So they have more experience than we do. That's a little unusual for us. Usually we get it first. We're US. We're pretty selfish that way. Us first. But that was the one instance where they got it first. To the best of my knowledge, no. I do think some countries use off-label, non-FDA approved therapies more than we would in the United States. We tend to use FDA approved therapies for good reason. But yeah, that's another good question. But I don't think so. But I guess I would have to double check. So.
Not a problem, because that was the end of the questions. Okay, so you did great. Now you can relax, go eat some dinner, go to bed, get up again.
Get up again.
Thank you, everybody. Doctor, have a great night.
As well.
See you
Thanks,
next time.
Stuart. Really appreciate it. Thanks for listening.